Yeah, the audience I want to explain, Dr. Wendy Nilsen was planning to join us in person, but due to some important commitment today and NSF, she has to deliver her keynote remotely. But really appreciate her support to the CHASE conference over many years in various ways, right? So Dr. Wendy Nelson, so we already saw you on the big screen. So I'm gonna just give a brief introduction, basically read your bio, and then you can start your keynote. So Dr. Wendy Nelson is a Deputy Division Director for NSF RIS Division. She has been widely recognized across the federal government as a leader in health technology research. She has long led the Smart Clinic Health program. I think not a lot of our audience are very interested in this program. Also, maybe also the awardees from this program. She has long led what's now called National Information Technology Research and Developments, Digital Health Research and Development Interagency Working Group. Becoming the Deputy Division Director in IS, she previously served as the Acting Deputy Division Director for Division Industry Innovation and Partnership, and also the Acting Deputy Division Director for Division of Engineering and Education Center. Joining NSF, she was a Health Science Administrator in the Office of the Director of National Institute of Health. Welcome, Dr. Wendy Nilsen. Let's give a applause.
Thank you so much for your kind introduction. I'm hoping my slides are showing.
Yes.
Okay, good. So I want to start with a huge apology. I had train tickets. I was ready to come, and I was super excited to see all of you. This is one of my favorite places to go. Both the Chase Conference in New York City, as a New York City native, I really was looking forward to this and seeing all of you. And unfortunately, we have an announcement here at NSF today that will not disrupt the science, but will disrupt the staff a bit. So I needed to be here. So I want to talk about, we've been talking about smart health, being smart. Are you guys hearing an echo? Because I'm sure hearing an echo. Okay, maybe it's going away. So we've been talking about smart health forever, and I often sit and as I'm thinking about this, I'm going, when do we get smart health smart enough? Is it smart enough yet? And then when I do that, and then I start working on I think about this, and I think it, I always start my talks with where are we at with health? Where are we thinking about with health? What's happening in the U.S.? And I thought heart disease and stroke was interesting statistics, but I think it's even more interesting in the heart disease. This is out of Cardiovascular magazine this year. But what I thought was really interesting is they start with diabetes. So if you look at if you look at this slide, you'll see, people are while I'm talking to you about this, at least one person dies of cardiovascular disease. Diabetes is over half of the US adults. Diabetes or pre-diabetes. Strokes are happening while I'm talking. There'll be many people that have had a stroke. These are serious issues. And, these numbers don't get better. They get a little better here, they get a little better there, but I think we all see the opportunities for this to get really better. And I think if smart health was as smart as it should be, these numbers would be changing. One thing I also want to say is we're not doing well when we look at compared to other countries. We don't have our lifespan is we actually started ticking up again. But if you can see, there's this huge gap between where other comparable countries, these are other countries the OECD countries. These are countries that have comparable, incomes, populations, everything. So you can see them at the bottom. But if you look at, life expectancy at birth is really, we're not doing well. And I think one of the other issues that we'll talk about in this, and I know you all will talk about, is the cost of healthcare spending is huge in the US. We spend more per capita than anyone else. And we're not getting the outcomes. I also think one of the things, I never talk about this, but can we actually access care? We talk about the money, and the money is important, because I think it's a marker that we're spending a lot and we're not getting what we need. But also, if you look at this, these are percentage of adults who reported barriers to accessing medical care. And there's questions about no source of care. That's often our rural areas. But then you start looking at difficulty paying medical bills, delayed or didn't get health care due to cost, worried about ability to pay medical bills. I just dealt with my adult son who said he had a cyst on his hand, and he said they put me with a surgeon. I don't know if I can afford that. Maybe I'll just let it sit for a while. I thought that was a really bad idea, and we worked that through, and it's fixed now. But this shouldn't be the way we're getting care, because my son delaying on that cyst, maybe it was no big deal. Maybe that cyst was just what it was, a cyst, and no big deal. But what if it had been a tumor? What if it had been important? It was going to destroy function in his right hand. This is not going to help productivity. This is not going to help his ability to earn a living. And he's got resources. He's got family, and he's got a good job. But, these are all things we need to think about as we're trying to improve systems. The other thing I want to say is, there's a lot of talk about government costs lately. If you look at the federal government, what we spend in a year, $6.9 trillion, health is 27% of that. So we're talking about a huge amount of money, and we're not doing as well as other countries. So I think this is an incentive for us to come at this with a new way of thinking, a new way of doing, a new way of being. So it's AI to the rescue. I am the Deputy Division Director and soon to be Acting Division Director of the AI division at NSF. So I believe that AI is going to make a difference. And I think the work that you all are going to do, AI or not, is really going to be a key to how do we get to the next space in this. I will say, when you look at the numbers, this is from Grand View Research, looking at the estimates for AI in healthcare market. There's a lot of belief that this will, that things will increase. If you look at it, North America is expected to increase more than anywhere else. I think it's because we're so far behind on doing these things. But when I look at this, I think, okay, $208 billion, that's a lot of money. But what are we going to do with that? What are we targeting? And I know a lot about what you all are targeting, but I was looking at what industry was doing. And Google has their it's PalmMed, I think, or something like that. Google has their large language model trying to include clinical knowledge. They're using some of the tests that clinicians get trained on. Really interesting, but with a very limited use case at this point. AWS has their Health Scribe, which is actually Nuance. Believe it or not, Nuance has been used in hospitals since the beginning of this century. So, but they're using it now to use Nuance in the clinic, to take it and summarize in a session without the clinician having to write what happened, but doing it based on the conversation. It's an interesting approach, and if it saves time in the clinic, if you think about how much time clinicians spend writing up what are often incorrect notes, not because clinicians try to write incorrectly, but because there's lots of things happening, there's lots of questions, there's lots of interactions that may not make it into a note, but which will impact things. There's a really interesting article written years ago. It's enough about you, but what about me? And it was actually looking at clinical encounters and how much clinicians talked about themselves. It makes me wonder, if we use Health Scribe, does that impact how clinicians are going to talk with their patients when they start finding themselves encoded in the notes? It's an interesting question to look at. But then I actually looked at OpenAI, said they were going to solve health problems. So I looked at OpenAI's, one of the things they do is this benchmarking task. And when you look at it, it's done well, it's nice. But if you look at it, what we're doing is trying to, use a large language model to really get a better version of what Dr. Google's done for years for people, right? Bring all that information together, make sure people understand this is not medical advice, even though they often are using it as medical advice. And this is what happens. This is not exactly revolutionary use of AI to improve health. It's just not. And so I looked and looked and looked, and I thought, okay, so we have these consumer and clinician facing chatbots. This is cool, using voice for data, which is really good. There's also a lot of interest in using mobile devices to be better to enter data. You know, electronic health records are not easy input devices. It's not an interface that's usable. There's been research in the past using mobile devices with an app to actually get data into the EHR. That seems like it's becoming more common. People are really interested in doing that, especially on some of these units. The Department of Defense did a really interesting study looking at burn units. Could you create an app and have doctors do what is a pretty standard process for reviewing patients every day through an app? And it worked well, and it reduced time, it increased the quality of the data. And I don't know how it ended up outcomes wise, but it was an interesting project. The other thing that really is happening, and actually if you look at AI, there's the scheduling optimization. The operations side of the house seems to get most of the AI attention in the world of AI. So there's a lot on helping patients self-schedule and scheduling surgeries so that they're more effective. There's a whole lot of factors that come into scheduling anything in a hospital, especially since there isn't just one person. So how do you think about scheduling? How do you optimize schedule? Lots of places have done a whole lot of studies. Mayo Clinic has done a lot of work in this area, trying to figure out how do we best optimize scheduling, both for patients and so that if you have to have a surgery, you don't want to know your surgery is in 3 months. People tend to be anxious about upcoming surgeries, and so waiting months is not a positive. But also to reduce burden on their clinicians. It might be that if everybody wants to schedule with the same doctor, if you can get an appointment with a different doctor sooner, often that helps reduce the burden on one clinician and improve the flow for others. So, this has been an area that's been a big one. Some of the medication checking has been a focus, and automation of some of the low-level tasks. So I think it's really important to note that 30% of our healthcare costs are administrative. These are not clinicians, nurses. These are people that are making phone calls, that are entering data, that are shuttling carts, that are doing all sorts of things. And many of these tasks, I mean, we've seen the medication robots moving through hospitals in some cases. But a lot of this stuff a lot of these low-level tasks could be automated in a way that might free up people for tasks that are more rewarding, but B, also more valuable. So I want to talk about where I think you all, or where we all as a field, should be thinking. And I want to really encourage you, and I think this is what you do so well, but I want to encourage you to keep doing it, is think differently. There's a real push to work with clinicians. Not that I don't like clinicians, really love clinicians. Some of my best friends are clinicians. But working so closely with them that we're working on their agenda. We're working on their problems. And I think you all have the ability to walk in and think about this in a very, very different way. think at it from a different perspective, from a different angle, um, and not just think of it from the way that the biomedical community thinks about it. Doesn't mean you should make up a problem. Sorry. Doesn't mean you should make up a problem. Doesn't mean you should ignore what's happening. But being able to stop, think about this in a very different way, and say, perhaps if we looked at this, you can appreciate that they have problems that they need solved, and working with them to solve those problems is it. But it doesn't have to be all you do. And I think what can be amazing is not just doing what a clinician thinks is the most important thing to do, or a clinical researcher thinks is the most important thing to do. Often clinicians have a very different problem than your clinical researchers will, because it takes so long for the science to get out. But really keeping your perspective in a very different way. So I want you to think about these are some of the areas that when I sit and I think about, I think we are still having questions about multimodal data. We are still talking about real world data. Many, many years ago, the real world data came up with Obamacare. Could we think, or the APA, Affordable Care Act? We thought we really talked about real world data for a while, but we're not getting there. Sensing new constructs, and I'll talk about that more. Thinking about underlying factors. I think it's interesting that diabetes and heart disease and stroke all get linked together. And improving operations and increasing access. Just because that's what's happening now doesn't mean it isn't still a good area. And then there's always a safety question. So, I mean, when I think about medical data, I mean, it's amazing how many times I'm still seeing limited data coming through. So, in smart health, we've always encouraged complex data analytics, complex data fusion, but we don't even get all of the data that we can get out of a hospital setting, no less other data. So often it's only a pathology, it's images from pathology, it's notes from pathology, it's radiology, images only. Radiology's actually had a boom with AI, but it's been amazing how little integration of other data came in there. I sat on a cancer panel at the National Academies recently. We put together a report, and one of the things was thinking about putting all this data together to get much better understanding of how what's happening in cancer and how we treat it. But there is so much data that is not integrated in records, it's not integrated in systems, and often people are working with a limited or working in a clinical setting. They think about their data. They don't think about other data. So that the people you're working with might be very limited in how they're thinking about their data. But I think coming from the technology perspective, we should always be thinking about how do we fully utilize the data, because clinicians are great care providers, nurses, clinicians, everyone are really good at looking at humans and being able to make inferences based on a holistic view of a human, but they're not good at integrating all this data all the time. I'm sure everybody sitting here has gotten a lab test that comes back off, and when you ask the doctor, they go, "Huh?" I had an image come back and it said that there was a tumor, and I talked to the doctor about the imaging, and he said, "Yes, the thing we were checking, it was perfect. Don't worry. I know you were in a lot of pain, but don't worry about it. It's fine." And then he said, "All right, thanks for talking to me." And I said, "Are we not going to talk about the tumor?" And he said, "What tumor?" And I said, "The one that's in the last line." And he said, "You don't have oh, you have a tumor. Wow, you do." But he was looking for the data that addressed his problem, the problem that he had sent me for imaging for. That tumor did not pop out in his mind because he had already answered his question. That's what humans do. That's not what we do. In our world, we can bring that data together and lose some of the biases that humans have because we can think about that data together. I also want to think about all the medical sensing data we have now. There's so many things, there's different things here. Some of these are older, but we are adding more and more devices, more and more specialties, more and more different ways to come up with data. There's earphones now. Shoes are smart, watches are gathering more and more, but there's lots of patches that are gathering, data with acetone, all sorts of interesting things. These are going to be able to be integrated in our data, or should be integrated in our data, in ways that are going to bring us ideas that we've never had before. And I don't think that the biomedical world is going to get them all together, because it doesn't even occur to them to put it all together. Also, the Internet of Things. Somebody said to me, the other day, do you think you could figure out things about depression if you looked at what people did? Oh, we've already been there. We've already worked on things like that. Doesn't mean we know all of it. I mean, there's even apps out now looking at, what's happening based on things that are happening in your environment, your Wi-Fi usage, your phone usage, how you're tapping your keyboard. There's all sorts of things happening, but and using that to infer health data. So, thinking about all these other things, there's a whole lot of information. Cars have more information than I don't know, than I can ever even think about. But we originally, years and years ago, I think in 2011, there was an idea to have your car sense your your blood glucose. It didn't go anywhere. Nobody wanted their car to not start because of your blood glucose. It wasn't exactly an appealing idea, but it makes perfect sense. But how can we use that data to think about things? Some people have been using car data to infer mild cognitive mild cognitive decline. Can we think about dementia from car data? But can we think about it even from buildings? There's some really interesting data coming out on vibrations in floors. There's all sorts of things now that, because we've so connected the world, the Internet of Things allows us to really think about how are these things related, and how are they related to our health. And I think if you think about one thing from this talk is, health is not limited to a biomedical setting. You know, um, if you're spending your day in a tractor, that tractor is impacting how your health is, right? We know that truck drivers end up with lung disease. They tend to smoke, but there's also the diesel fumes. So there's all sorts of things that are impacting you that have nothing to do. We worry about the smoking, we don't think about the diesel. So how do we think about that and help people? Is part of that is getting the data to the point where people can understand these relationships are much more complex than we've often thought they were. So if I think about multimodal data, I think about fusion, I think about analytics here, I think about how we can really do that. I think really merging our health, our traditional and non-traditional health data. It was interesting. We funded a project a couple of years ago in COVID where a researcher worked with industry to figure out who was in the home and the spread of COVID. But it struck me as really interesting that industry has all this data on who's in the home. We don't think about that. We know what people eat based on, if you're a company and you're trying to sell food products, we know what people eat. Um, there's all sorts of things that we could think about, and bring together in a very complex way to really get new answers to these old questions. Um, you know, Diabetes, we think about blood glucose, we think about diet and physical activity. But how do we think about that differently? How do we turn all those problems on their head? Maybe could we do a data-driven approach to this? Could we really think about, this morning I was driving in, I was listening to them talk about how heat, we're having a heat wave. I know you're having one too. How that impacts sleep and how it increases the episodes of sleep apnea. And I'm just thinking, with all the data that we have out there, we could really kind of do some interesting analytics about how does that happen. They're looking at very small samples, right? You got it. We put a sensor under your bed and we're looking at the temperature outside. But what about the temperature inside? What about all these things that would be really interesting? Because it might be people sleep fine if they had access to a certain temperature. How do we think about all that? But stepping back and not looking at it in the traditional way might be really good. Can we add context into this? Because when I was listening to the sleep apnea thing, they never talked about indoor temperatures. I was talking to a colleague in Arizona one time, and they were talking about older adults dying in their homes because their homes were so much hotter than it was outside, which is disturbing when you realize how hot Arizona is. Um, but we're missing that context. And I think I always love this sign, context matters at the Stephen King Diner when there's shepherd pie for dinner. But context matters for everything. It makes so much difference. We know that we eat differently when we eat with friends at a table versus eating at the TV, eating alone at a fast food. All of these things impact how we do, but we don't have the methods and models to really think about that in the way that might really help us understand how context is driving these behaviors. There's an interesting study in diabetes that showed that standing up for 30 minutes after your meal impacted your glucose. It's really interesting, but how do we think about that? How can we get the complex data and really start to think about that differently and see that as a long-term trajectory? I think aging in place is a place where we could think about this a lot. Aging isn't just about disease. We talk about disease all the time, but really, do we have to think about age-related? Can we think about age-related limitations? It's not just it's not just do you have cardiovascular disease or diabetes, but can you walk? Are you eating enough? Some of the smart homes have started, having sensors in them so that you can microwave food correctly, noting what you're eating that way. But how do we think about this social behavior? Where are you? If you're sitting in the bedroom all day long, is that going to give you a different health outcome? Then you went out, you walked around the neighborhood, or you went out and sat on the front porch for a while every day. There's so many different ways we could think about this, and they're so complex that asking humans to just think about this doesn't get you to the place you're going to need to be, but we can think about this and think about how do we get AI to help us answer these questions by bringing together this really complex data and thinking about all of this differently. I want to think about real world data because real world data is critical to how we think about this. Again, when the Affordable Care Act came out, real world data was a question that the FDA got tasked with. How do we use real world data? Now, real world data at that point, we were talking about Fitbits. We were talking about, really patient generated data, Fitbits. Patients like me was having at that point was really kind of a thing. People reporting their own data and bringing it to the doctor. How do we use that data? But now when you think about real world data, it's a huge amount of data. Why can't we use data in health like we do in industry, in other industries? Why can't we think about this very differently? So, most health is happening outside of the healthcare system. How do we bring in that data that really addresses all of the things that are happening in our lives? How do we start to think about that in a very different way? How can we look at these standard health problems? How do we look at diabetes in a very different way when we think about this with new data? It's interesting now when we've started with new drugs for diabetes and obesity. This is the rage. But, it's interesting. All of a sudden, we're seeing relationships between things that we thought were there, but we didn't really realize as people are losing weight, different things are happening. It's a really interesting question. When you think about cholesterol, when you think about cholesterol goes down with weight loss. Is it just that you're eating better? No, it appears to go down with weight loss. So how is that? What is that mechanism? How is that working? And I think one of the things that I think as technology people, we can think about health as more broadly than disease, right? How do we think about these things as a connected, as a closed loop system? We are a multi closed loop system because we're really a complex dynamic system as we think about it. But we really need to think about health more broadly than just disease-based. I'm pushing on data, but I think data is the thing that makes our world stand out in a completely different way, because data is one of the things that is key to our world. We're either adding data or we're analyzing it, or we're doing both, all of the above. But there is no other world that looks at data like we do and thinks about data like we do. And I think in health that's always been missing. There's been so much of an idea that it always takes human judgment to not to think about. And I'm not saying you move this to the clinic right away, but can we really think about how how things work together, um, and how do we look at a data-driven approach? You wouldn't start with that. You wouldn't say let's just move a data-driven approach into the clinic. That's not the way research works, and that's not the way health works. You can imagine, though, you can make a parallel system so you can really figure out what's working, what's not. How do I think about this? I often talk about a project that was the control tower, for surgical, for anesthesiology. Brought together a whole lot of data, but what was interesting there, we funded that project when it first started to build the algorithms, to build the data fusion on that system. And so it was putting all of the surgical data and anesthesiology information into one system. They then went on to run the system. They trained the system to identify problems in anesthesiology, where anesthesiologists might want to make a choice. Do you want to add this? Do you want to reduce that? I'm not sure what anesthesiologists reduce and not, so I'm not going there. But what they found out was, when they looked at patterns over time, they found out some decisions made better outcomes than others. There's a lot of things that anesthesiology and surgical things can affect. So what was interesting was they ran side by side with a clinician. After they developed all the algorithms, they ran side by side and they asked clinicians, why did you do that versus this? And then at the end, they did a clinical trial. Now I believe it's actually approved by CMS for use in clinics, because it's had such a great outcome. But it was a data-based approach because the team decided this should make a difference. We see all these bad post-surgical outcomes, and we're not sure why they're happening. The data should tell us. And I think we have to think about that and help our biomedical colleagues say, we can do the problems that are important to you right now, but let's get this longer term strategy of thinking about that data, putting it together, and coming up with a new way. I also want to sense new constructs. Cytokines are an inflammatory marker. Cytokines mark so many different things. And I was talking one day with one of my biomedical friends, and they said, could we sense cytokines? And they were like, no. It wasn't even worth having a discussion, at least from their perspective. It was, no, go away. Stop talking about that, because that's impossible. And I think it might be impossible. I'm not convinced anything's really impossible. But cytokines are interesting because they're markers of inflammation. They pop up in all sorts of ways that are really important for understanding when people aren't doing well. So when you think about that, cytokines would be a great thing to mark. I mean, in diabetes, we're always looking at glucose, but glucose is really kind of an incidental. It's riding along as an indicator for insulin. Do we pull insulin? Can we sense insulin? There's some new implantables that look like they will be able to, but how do we think about these things? And I think in the past, we've gotten markers like glucose that we are so tied to. There's a whole lot of markers in health that the health industry gets reimbursed for. So, you think about cholesterol. Cholesterol is important. It's one of our markers. But they have to keep measuring cholesterol. If you're not getting cholesterol drugs and your cholesterol is high, that's a HEDIS measure, and it's actually, the hospital's not getting rewarded for that behavior, because they're supposed to convince you to get your cholesterol down. However you're going to do that, they get responsible for that. But we get so tied to these markers that it leaves us in a different position than I think we could do if we stopped and looked at the data, or we asked some of those underlying questions and started to sense some of the things that we can't do at all, or we haven't been able to do at all. And we can do them in blood, but can you do them less non-obtrusive and minimally invasively? So can we think about that? Can we think about all the things that we can do now in different ways? Can we, again, capitalize on the Internet of Things? I also want to think about, instead of, we often get asked, can you measure this? Because we want to think about this in treatment. But can we start thinking about underlying mechanisms? Brainstorming on all the things that could be. There's an interesting project that NSF funded that was looking at tumor temperature. So some tumors respond really, really well to their oncological treatments. So their cancer tumors, they respond really well. Others don't. Why do they not respond? There was some hypotheses, some data that really suggested maybe it was the temperature of the tumor. Was it not making an environment where the drugs were doing well, or what? So, somebody built a sensor for temperature in a tumor and tried to create a CPS, a closed loop system, where they could adjust temperature there, and try to see if it was going to make a difference to how the drugs were acting. So, these are early stage, they're really preliminary, but they're interesting ways, sorry, to think about how do these things work together? How do we get to those mechanisms? And also, there's always new modalities. I put this image. This was just project just released from NSF, looking at new imaging methods, taking images and looking at cardiac images, biological cell images, all sorts of things in much, much finer detail than we have in the past, but using our existing data to really think about it. And also, I think about dynamic imaging. I think about some of the imagings from our lives. There was an interest in how do we capture some of the images in our world to understand context, but we're a long way away from that. Yeah. Thinking about the underlying causal factors, I think is really, really important. We always assume that traditional models are correct. Remember, when you're responsible for keeping people alive, having faith in your models is kind of a key protective factor. But doesn't mean we don't have to deny that the traditional models are correct, but why can't we think about it differently? Why can't we why do we have to treat diseases as independent? Why can't we think of continuums underneath? And I bring back the diabetes, heart, and stroke. You've got this really huge issue between, and they're talking about the sugar and glucose, the sugar in your system affecting your cardiovascular. How are these things really working, and how do you think about them if you stop thinking about heart disease or diabetes and you start to think about a vascular system and all of the impacts on it? How do we really think about that? And can we model that system? Can we think about that system in a very different way? That also gets relationships that humans can't see. Some of the data-driven work helps us think about how are things that we can't see, or that it's really hard for a human to infer because there's so many different variables there. Again, I don't want to give up on improving operations and increasing access. I think that's really a key. There are so many costs in health that are not wasteful in the way that people just don't do them, but they are wasteful. 30% of our healthcare costs are administrative. I've told you that before, but soak that in. There's a lot of money in that. And if you look at the staffing in hospitals, it's kind of striking what percentage of the hospital is actually administrative and what's not. And it actually turns out care teams have gone down, administrative teams have gone up. So making these processes more efficient, optimizing processes and workflows, thinking about them differently. I remember I had a colleague who was an operational engineer who got himself checked into a rehab unit. Wanted to see what it looked like from the ground. It didn't look good, by the way. But thinking about those processes, thinking about those workflows, helping people think about them differently, reducing time on tasks. If you can take 6 minutes out of a patient visit, 6 minutes out of time that gets around that patient visit, providers really want, whether they're nurses, doctors, or what, really want to be able to do a good job. They're working really hard at that. But when you're spending all this time documenting, getting into systems, documenting all these things, you're wasting a lot of time that you could spend preparing for a patient, thinking about a patient, working or having a patient in your office with. So thinking about reducing time on task becomes a huge potential value for a patient. And then improving communication flows. You shouldn't find my tumor because I told you there should be a way that we can actually communicate that easier. For access, I think about years and years ago, I did an interview and we talked about doctors in your pocket. I didn't want to reduce clinicians. We wanted to talk about how do you get that kind of support, and not just clinical support, but lots of what doctors do is about lifestyle. It's about behavior. It's about eating better, doing more, walking more, exercising, this, that, and the other thing. How do we get that support? How do we move that into the real world? Having a doctor in your pocket, kind of, can't we do this with AI? Can't we give prompts and support and things that are really going to help? I think all of the things that make things more efficient also increase access, because if we can reduce the costs and the problems associated with healthcare right now, um, we can really think about reducing cost and making everything more accessible. And again, the cost of errors, it's all over the place. Nobody really knows what errors are. And let me tell you, there's a million definitions. The national academies have had many. It's not easy, but there's also duplication. There's all sorts of things that happen twice, 3 times, 4 times. People are touching the same data multiple times and not getting an outcome out of it. We need to think about that. Safety is always an issue. Um, Privacy and security standards are not working in this AI era. I mean, think about it. The amount of data out there, how do we think about this? How do we access the control? There's been so many hacks on healthcare systems. It's not just for your Medicaid or your insurance numbers, but your Social Security, all sorts of things. Um, we need confidentiality. We need anonymity for this data. We want to bring data together. Can we guarantee that? Can we guarantee privacy? Can we make sure there's trustworthiness baked into these systems? Because right now it's a real challenge. Accountability is always something in the healthcare world, and it's something people really believe in. Medical device security is the other. We always are worried about how our devices are working. We spend more time worrying, I think, about our wrist worn devices than some of our actual medical devices. So I just want to end this by saying, bring your ideas here. Think about everything differently. It doesn't mean you dump your partner and you start something new, but sit with your partner, brainstorm, get a cup of coffee, talk about all the things that if you could do something different, if we could just get in the real world with this, what would we do? What kind of things would happen? How can we think about that? And bring your science to bear on that, because I think without that, we don't have a chance. And I think while industry is doing all sorts of things, they're going to remain focused on profit. And profit is going to focus only on big diseases that get funded, right? Let's work on cancer. Let's work on heart disease. Let's work on diabetes. Those are the big three. Those are the big three killers. There's a reason to focus on them. But there's not a reason to break that mold, because as soon as you get funded for that, as soon as you're getting paid for those problems, there's not a real reason to get rid of them. So think differently. I think this is why your work matters so much, because this is how we change everything. This is how we change the world. And as someone like all of you who is aging, I'm looking forward to seeing what you do, because I know I need you in my life. And I think the whole country does. So thank you very much.
Thank you, Dr. Nilsen, for your wonderful talk. Any questions?
Or she turned off her microphone.
So Dr. Nilsen, you are muted, I think. Yeah. Any questions?
I'm not hearing you.
Because the microphone here, so I think it's
I'm not
fine,
hearing
right?
you in the room. I can't
I
hear
can
you.
hear you. I can hear you.
Oh, there you go.
Yeah.
Okay.
Yeah. Yeah. Go ahead. A question from audience.
Hi, Wendy. This is Fan from Stony Brook. So good to see you again. um, I think you're muted somehow. Okay. So thanks a lot for the talk. Actually, my question may not be so technical. It's more on the overall big picture for NSF, the funding situation. I think understandably, everyone in the community is quite concerned about what's going on right now and what might come. I think there's news yesterday. The NSF, the whole building is supposed to be taken over by HUD. Uh, so um, actually, I do have some ideas of some proposals that I want to continue to write and submit, but all the news coming in really cast tons of uncertainty on how things are going in general. I don't know how much you would be at liberty to share, but if you can give the people some insights about what's going on and what might be best strategy for us to handle the uncertainty and try to continue with our ground proposal research work and so on, I think that probably would be very helpful for everyone. Thank you. Thank you so much.
All right. And thank you. And I just want to say thanks to everybody for doing what they do because we know the uncertainty is huge. So, yes, we're losing our building, which is why I'm here today, not with you all. Um, that won't hurt the science, but it's pretty disruptive to my staff, that's for sure. So, I want to say, so we're working on revising how we do things to make sure that it's echoing like crazy, isn't it? Is it echoing like crazy? Sorry. Thanks, James. Okay, that's better. Yes. Can you hear me? Good. Okay. Um, so we're really thinking in size. How do we optimize how we fund everybody? Smart Health is continuing. We are aware that's an important relationship with NIH, and even when we have less money and they have less money combined, we work better together. So I'm really grateful for that. But I will say, I think we're all scared about the financial aspects of everything. You do have options as citizens in this, but also think about when you're putting in a proposal, put in your best proposal. Sometimes I see people put in two proposals for every initiative, and they're not. They've got some overlap. Put in one. Do a great proposal. Um, we're gonna do an office hour on career this week. I'm gonna encourage people, if you're not ready, don't put it in right now. Don't put it in when they're tightest. Put in these really, really strong ideas. We are trying to narrow, we're trying to not have 100 solicitations out. So we don't fund one or two of everything. We get to fund the really exciting stuff. We are looking forward to the one thing that I think is the bright spot is AI has been identified as a key area. AI, quantum, biotech, which is smart health, by the way. Smart health is AI and biotech, so I think it's a dual winner. And then nuclear, but I'm not sure we're nuclear, so I don't think we get anything off of that. But as you're thinking about that, think about putting in the best proposal possible. If it's in, and I know everybody needs the funds, but don't put in, just be really careful, really strategic. Talk to your program officer before you apply. Really spend that time on a proposal. It's easy to put in more than less, but I think less is going to get you more in the future in the way we're doing it. We are trying to, one of the things at NSF that we're doing in my division, because we have the most amazing people ever in my division, is we're really looking to not only reduce the number of solicitations, but hopefully that allows them to focus on less things, so we can continue, even with less staff, being able to do really high quality review, which we've always been considered the gold standard for review, and we're going to keep doing that because that's where my folks are. But we're hoping we can reduce their burden too, so that we can continue to do this in a way that makes sense. So the one thing I will say is citizens and scientists should be blasting from the rooftops how important science is. Encourage your universities, encourage your leadership to be highlighting all the amazing things that you do. If you notice, NSF is putting out more press releases than ever. I think I don't think people understand what we do. I don't think people get it. And what you do makes a difference. And whether it's quantum physics or whether it's smart health, whether it makes a difference this year or 10 years from now, it makes a huge difference. So thank you for all you do. But make sure people understand it, and understand it in a way that makes sense. Because it's hard for most people to understand our world in a way that really connects for them.
Are you ready for another?
Okay.
Oh, Wendy, are you there? Can you hear?
Yep, James.
Yeah, of course, right. Hey, Wendy, this is Jim Weimer. I turned it off and turned it on. Can you hear me now?
Okay.
All right.
Yep.
Hey, how's it going, Wendy? So my question comes from a kind of something I've observed at the conference here. My paper I presented, it had absolutely no AI in it, but I might be the only person here presenting a paper with no AI in it. And that was largely driven by the fact that I've spoken with the FDA and been informed about the regulatory hurdles of getting an AI solution through for that specific application. Are there availability for those researchers that would like to have access to it to be able to NSF support to pursue better understanding of how this technology we're developing will get to market, so we can avoid certain hurdles? If I had presented an AI-based version of this solution, I wouldn't be able to get to market. As it is, I'm presenting a non-AI-based version that I know I have a pathway to seeing my research actually affect patients.
Thanks, James. I think this is an important question, although my friends at FDA keep telling me they've got a space for AI. AI is also, remember, we think of AI in computing as a very specific area, but when we think about AI broadly, it's much broader. So don't think if you're not doing AI, but you're doing something else, you're doing machine learning, you're doing data mining. This is a broader area. We're not trying to pinhole. I do think we've worked with FDA for years, and FDA says they're embracing AI. Learning systems are a super challenge for AI or for FDA because they're a challenge. This is a question though, James, that I think TIP, our Translational Innovation Partnership Group, should be tackling, because one of the questions for this is, how do we help them think about benchmarks? How do we help them think about, I sat with the FDA group for so many times talking about, like, what do we do about large language models? What do we do about generative AI? How do we think about this? How do we think about learning systems versus analytic systems, right? Because if we analyze the data and we come up with a model and FDA approves it, that's one thing. if my model keeps improving or growing or changing, it continues to train. We've seen, like, ChatGPT used to be really good at math, and it got worse and worse and worse. That's fine, unless it's your kid using ChatGPT to answer their math, and then they're probably doing lousy, and maybe that's a good thing. So maybe they'll actually pay attention to math. But it's really going to be a bad thing if that's how it's figuring out your glucose, right? So, how do we think about that? I think that's a super challenging question. And I think that's one of the questions, to me, that's one of the computing questions, is how do we get better understanding how systems are learning and training so that we can build that into a regulatory framework? Because often we're doing prompt engineering, we're doing all sorts of things, and we're changing how we're doing things, and I think that's always a challenge. So does that help? But I think that the science on this is a tip issue.
All right. So, yes. So, Wendy, can you hear me?
Yes.
Oh, okay, great. So, this is Wenjing Lo from Virginia Tech. So first, Wendy, I want to just say thank you for your service as a program director. So because we are all heard so many news about NSF, particularly I think yesterday, right? So as a former program director, so I value my experience at NSF. I met some of the best people at NSF. I truly believe, it's the people serving NSF need some patriotic, the loving their country, the heart to do their job. So I was there at the best time for myself, I guess. So, but I totally understand the hard time NSF is taking at this time, right? So, yeah, so thank you very much, and thank you, and all the NSF people are what you are doing for the community. So thank you. So my question is I think it's about the program, right? So I do cybersecurity research. So for recently, I was working with hospital people, and we're developing some particular security and privacy mechanism for healthcare system to protect healthcare data security and privacy. So for ideas like this, like a privacy in healthcare, so for idea like this, is this how do you differentiate a kind of idea like this in SCH program and also in SATC program? Because I got most of my grant from SATC, but if the idea is particularly for healthcare, is it suitable for SCH program?
So I think first, let me start with saying thank you for your service. Everybody here, everybody at NSF, I can't tell you, every single person I've met, almost down to the letter, comes for the passion, comes for the mission. They care about science. This is what we eat, sleep, drink, think. Everybody cares about it, and I think I will tell you that my staff have it's been a challenge at so many levels, but it really has been a challenge. One of the things that I hear every single day is, how does this affect the community? So please know that you all are first and foremost in everybody's minds. So, but thank you for your service on that. I mean, so what do you do when you have programs? This happens all the time. So you get, is it SATC because it's privacy and security, or is it smart health? I get this. Is it a math proposal when it's mathematicians doing it? Is it a math bio proposal? Is it a smart health? I would suggest taking your one pager and sending it in to both programs and saying, SATC funds quite a bit of the projects that happen in the healthcare space or in the around health data and that too. We've always, so often we will work together on those. It isn't like, well, if you've been here, you know how things work. But for those that don't know how NSF works, when Goli Yamini and Tom Martin, who runs Smart Health so well now, get a proposal that's privacy and security, they call up their SATSI colleague, which is, for us in IIS is Dan Cosley, who's wonderful in our HCC cluster, and say, Dan, would SATSI be interested in this? He brings it to the SATSI group and says, here's a project. And so we work together on those things. So I think sending a one-pager first to both programs and seeing who's more excited by it, because often the focus is just a little different depending on where you're going. But at the same time, if it comes to one or the other, we'll talk to each other. SATSI talks to Smart Health talks to SATSI. I talk to math all the time, math talks to me. So, and engineering, we all talk all the time, and honestly, we talk even more now.
So if there's anything that we can do as a research community.
I can't hear you. Oh, there you go.
Thank you very much, Wendy. So if there's anything that we can do as a research community, to influence the Congress or anything like that, please just let us know. We will be happy to do that. Thank you.
Okay, thank you. And brag about your science. Brag, brag, brag. And make sure you note when NSF funded it, because that helps everybody. So, but please brag about your science, because what you're doing is amazing. And I think our representatives need to understand what you all are doing. So.
Okay, thanks, Dr. Nilsen. Thanks for your service. We close this keynote session. Let's give a larger applause to her.